Dr. Maybank and Dr. West. I'll be using a lot of analogy. We are in March Madness. I am a former student athlete, so you'll get a lot of references. And Dr. West, your alma mater, University of Louisville's women's basketball team made it to the Final Four, so we have that. And as the moderator, I get to ask the first question, so I'm gonna take what the defense gives me and do a combined question as the audience prepares their own questions. So following the murder of George Floyd, June 2020, there was a resurgence of discussions and various learning opportunities regarding race and equity in medicine. Now that we're almost 2 years removed from Mr. Floyd's murder, what practices are your respective organizations implementing to keep the press on, or to keep the pressure to have the standardization of equity education within the pipeline? So as soon as a student matriculates and starts their first class, all the way up through practitioner. And with that in mind, also, how is it that your organization is working with your respective institutions so that when the students enter their clinical work, they will be around social-minded preceptors? So the reason why I bring that up is I'm still in training. I'm a resident. Every single person from nursing, respiratory therapists, attendings, subspecialists, NPs, PAs, they are helping me learn. And I'm a young, impressionable mind. So starting at my institution, our second year, if I'm being sent out to communities to serve, or students are being sent out, how are you having the standardization that they are being taught by social mission-minded providers?
Do you want to, it doesn't matter either way.
Okay. Well, I think when we're talking about the internal curriculum of the schools, then we are constantly providing more resources for them. As I said, we have a repository of many, we actually put together a 3-page repository and posted on our website for the faculty and deans to draw upon if they wanted some type of materials and so forth. But our D&I group, our team, is open to going there and helping each school in any way possible that they can. So I feel like the schools have the resources if they need them as far as curriculum and so forth. Internally in our organization, we still have our committee, our staff committee, and I meet with them every month to talk about any issues that come up and if they want to talk to me about it. And we have regular scheduled presenters that they select to come and talk with the staff every quarter. So we have that. As far as the preceptors, that's a really, really good question. And we don't have as much control over that because they fall under, a lot of the practitioner basis. If they are faculty at our school, then if they were seen to be not as receptive to the school's concepts, then there would be some issues. So it depends on the school, the practitioner and the preceptor's relationship to the school as far as if we could do anything major. But I'm certain that the schools, it would be up to them, would not want to send anyone to an area where the students would be uncomfortable. Because I think part of any successful preceptorship is having both the community and the student be comfortable with where they are going. And unless you have that from both parties, it's not going to be successful.
Thank you, and great questions. So I'll take this on several levels. So, I'm not directly engaged with med students in that way, but I am engaged in the AMA as well as the Center for Educating the Physicians and the Preceptors and Faculty, or the opportunity to do that, I should say. And I mentioned several of them, in the presentation and talk in terms of having the resources through the AMA Ed Hub and developing new content, making sure we're vetting that and making sure we're doing partnerships to provide what we think is really front-of-line education for physicians and other healthcare providers in the space. But fully understand your context in terms of not having faculty who are comfortable and knowledgeable to even talk about these issues. And so our kind of couple to that, which I did not talk about, and that's a whole nother presentation, is the work that we're doing with healthcare systems now across the country. So in January, we just launched, it's called the Peer Network, and this is engaging 14 large health systems across the country, led by my team member, Karthik Shivashankar, who is a vice president over Equitable Health Systems. And basically, it's an intensive year of which we're working with them to improve their systems and know the knowledge and the skills behind embedding equity and anti-racism work through their quality and safety systems, but also building spaces for psychological safety. So we are providing very intensive support around that, building on models that he developed at Brigham's, and this is actually a partnership with Brigham's as well. And so that's one way in which we're working with hospital systems as a whole. And then later this year, we, in partnership with IHI and Race Forward and the Racial Equity Institute and several others, ACGME is going to be a part of that, American Hospitals is going to be a part of that, launching a larger national healthcare initiative really focused on kind of utilizing organizing models to help support, again, pillars within our ecosystem. So when I say that, I mean like the associations and societies. What is it that they can do to really organize and operationalize equity and anti-racism work as a collective, but also hold themselves accountable as individual institutions and collective ones, working with the regulatory arms and working with Joint Commission in that effort as well, but also engaging the hospital and healthcare systems, individual providers, and payers as a sector to start really putting forward intentional opportunities, strategies, tactics, metrics that explicitly call out anti-racism opportunities within their institution. So, you know, the way that we are working to support the student and the resident and other learners in the space is helping support transforming the institutions themselves. So again, the culture is responsive, as well as the structures are relevant and also more equitable within the space. And we've been working with AAMC over the last couple of years, who will be putting forward competencies very soon, unless I missed when they came out, but specifically on diversity, equity, and inclusion across the spectrum of the life cycle kind of the student or the healthcare professional. And then lastly, just to respond to the first part of your question as it relates to George Floyd, you know, our strategic plan is our opportunity to hold ourselves accountable as the American Medical Association. It is, again, I think, definitely influenced and inspired many across the ecosystem of health, but also in other places. But I will say, as many of us know who are doing this work, that there is absolute fatigue that is happening as it relates to doing anti-racism work. And I'm not talking about there's already fatigue and exhaustion from those who've been doing this work for years. It's exhausting. But for those who are now kind of newly in the space, you know, made commitments and pledges that haven't been used to dealing with or naming racism or seeing it, you know, and having conversations about it, are getting exhausted, and they don't want to talk about it as much as they have before or engage in those discussions. And I see the quelling of people or ideas and conversations within my spaces and outside of my spaces. And I think, you know, again, it comes back to what I said at the end of just that courage and that opportunity to operate in solidarity and keep pushing this message forward of the importance of the work that we're doing, but the critical nature of the work that we're doing for society and humanity. And then the other part that I also am seeing, you know, in this space of, you know, it's not just clearly George Floyd. That was a moment, you know, in time, and we all are well aware police brutality has been around since the beginning of this country, or not even the country, but folks, colonizers coming to this land. But we also now in the space of that, the rising resistance, which is not new also, as we all know, to our country and our space, isn't it showing up clearly in our medical institutions? And over the last, I would say 6 months or so, there's been lots of reach out from physicians of color who are experiencing discrimination very explicitly. And this has always been there again. I'm hoping what's happening is that physicians of color and those who have been marginalized, and especially Black physicians, are feeling that there is a space for them that is receptive in a way that hasn't been before, for them to articulate their experiences in ways that they haven't. There are several major news stories that have come out, but I think all of this is happening, in the context of kind of post-George Floyd per se. Right now there is not a good space to figure out what to do and how to support these physicians. There just isn't. We need an equal justice initiative equivalent in the medical space as we have in the quotes criminal justice space to help support folks. And so, I see all of these as, long-winded answer, I know, to your question, but as an opportunity, again, to kind of wrap around, to support, elevate, all these different aspects of that just have to happen at this point in time. Again, I think because if we don't push at this point in time and break through the silence and the fear, these doors close, and we see it happening. It's happening all across our country, politically and in our structures. And I don't think it's the scariest moment in time in our history, but it's definitely a scary moment in our time in history in many levels. And so that's my answer. You're welcome.
Okay, thank you. Before we go to our next question, I do want to read a comment from our virtual audience. They want to say thank you for your thoughtful and sometimes difficult questions to hear. Introspection, not everyone wants to do. The Black doctors, Black patients narrative has always bothered me, despite the congruence data. Balancing racial conscious data with how it may be misused is difficult. I appreciate your insights.
Thank you.
Yes, sir.
Well, Dr. Chen asked me to comment on what the ACGME is doing in the space in the previous question. And Dr. Maybank, you talked about a couple of things that we're involved in at ACGME. We're working along with the AAMC with their competencies that are soon to be released. It was the GDI meeting last week, and they said they're coming out any day now. Mm-hmm. And the work that we're doing with you with respect to the equity grand rounds, health equity grand rounds, which is also very, very important. But we're also an accreditor of all of graduate medical education. We've implemented new common program requirements to address the diversity that we need to have in our programs, as well as improving the inclusiveness of the learning environment. And our colleagues in CLEAR are now starting to incorporate elements of this within the clinical learning environment review. So that addresses some of the things. We've also developed a program called Equity Matters, which really helps to develop an understanding, to acknowledge and to accept the historical basis and the realities of what occurs in our societies today, along with an action step and implementation steps of how to improve it through looking at engineering your system. But I do have a question, and it is related to the comment that just came through and something that Dr. Maybank said. When you survey medical students in their first year, and again in their fourth year, you ask them whether they're going to serve an underserved population. White and Asian students are in the low 20s, high teens in terms of percentages of people who say they're going to do that. African Americans are around 60%, Native Americans around 50%, Latinx Americans around 40%. The question is, if you don't depend on racial concordance, then we're going to have to try to figure out ways of improving the thinking processes of those white and Asian students who are admitted disproportionately in medical school to believe that they should be taking care of disadvantaged communities. And the problem, of course, with that is that we see that it hasn't worked until this point, and we have come to accept health disparities as part of what exists in our society. Like the poor will always be among us, people with health disparities will always be among us, and that's an unacceptable way of approaching it. So how do we instill in those young people who are not choosing to want to work in disadvantaged communities and feel comfortable working in disadvantaged communities to become more comfortable with that and see it as their problem as well? And the question arises secondarily to that, are we admitting the wrong white and Asian students to medical school at this point?
That's so light, Dr. McDade. I'm going to take a little bit of my AMA hat off. I don't even know if that's fully possible, and somebody will probably tell me that's probably not. Yeah, yes, I don't know. There's some aspect I don't know how we convince people to care and to love one another. I say now that my job, I get paid to convince people to care about other people. That's what I feel like I do, and that's, to me, sad and exhausting and tiring. And so what do we do in the meantime? Well, we're doing part of it, right? We're organizing and we're putting forward in this way, but how do we have big shifts? I think that's perplexing, but what I do think is an opportunity, and this is where the AMA hat goes off a lot, is how do we build out other models of care, and how do we revolutionize how we think about care, who can provide care in this country, and what does care fully mean? I think it is of value to be on a panel and in conversation with another discipline, such as dentistry, because that's also really a bizarre kind of segregation of the mouth from the rest of the body. And how do we think about care differently in that context? How can we learn and build together as disciplines? But also there are other caretakers and other types of healing. I think, Rupa in her book Inflamed really highlights this, but many people have, as many of you all know, in terms of other models of healing and health and prevention and other types of healthcare providers beyond physicians, and the value of nurses and dentists and midwives and doulas and all of these folks that have been around for centuries that have provided healing, and I would say sometimes with a better frame and context of love and value and connection to their community. And the value of community health workers, and again, that proximity and that context and that closeness of being, in the same space of those you are caring for, I think is really important. And then really throwing off like my AMA hat, of context of, what does it mean to be a revolutionary doctor, and thinking about revolutionary medicine and looking to other historical spaces and countries and some of the lessons taught. I'm engaged in putting aside some level of the political context of it, but from being in Cuba several times, and Joaquin and I were there a few years ago together, and learning just these different ways of being and thinking and connecting with people, and students being proximate and in neighborhoods of where they were serving, in homes of people that they were serving, not in a top-down kind of patriarchal way, but in a way that was of meaning, of real meaning and of value and of closeness. I think that's the shift in care and thought around care that we have to have in order to get there. But we all know it's an uphill battle, no doubt about that.
All right, yes, ma'am.
Hi. Hello. Okay, can everyone hear me? Okay, great. Good morning, Dr. Maybank and Dr. West. My name is Rashmi Krishnasamy, and I'm with the Beyond Flexner Alliance. I'm a public health professional by training. I just finished my MPH in community-oriented primary care at the Milken Institute School of Public Health in 2021. Dr. Maybank, I just want to say, and I'm going to try not to fangirl too hard here, that you are such an inspiration to aspiring physicians like me. And if I become a 10th of the physician advocate that you are, I would have surpassed my vision for myself. But my question is,
Thank you.
my question to you is, you highlighted the violence that academic medicine and just, dare I say, health professions more broadly have had on communities of color over the last hundreds of years. But I'd like to kind of turn inward for a second and consider the violence that the institution perpetuates against its learners and folks like you, advocates who are just doing their job of advocating for their patients and just doing the right thing centered around love and compassion. And And you spoke a little bit about the ARC framework, but if you were to give recommendations to institutions and health professions leaders in their institutions about protecting and creating safe learning environments for their students who are advancing anti-racism work within their schools, what would you say?
Yeah, thank you for the question, and thank you for the compliment. I'm going to answer your question, but I'm going to also say it's been a rough 4 months, 5 months, I guess, maybe a year, and ever since the JAMA incident happened. It's been really heavy, and emotionally it's been tough, and the threats have been tough. But I also couch it in the context of like Ida B. Wells, and all that she had to do, and, counting lynched bodies across the country in environments that were really unsafe, but all the other folks who in this time, present time, also are struggling with real major harm. But I say that all to say is that I'm really happy to be in person. I don't think this is like probably the largest in person I've had since COVID. And that kind of compliment is just really helpful. Sorry.
Yes, sir.
Trying not to do that. But this work is a lot, and a lot of people are going through a lot. And so in terms of institutions, and what they can do and what they should be doing, first is just naming racism, white supremacy. I'm even like shifting from saying racism, but white supremacy and patriarchy, because to me, that's the umbrella of all of this. The racism is kind of the fuel for white supremacy. But we have to be able to name what the root cause is of what's happening for people. Thank you. And so our institutions need to name that. I think as first and foremost, the leadership needs to name it, and they need to hold their leadership accountable to all these pledges and strategies that they put forward that are professing that they want to advance equity and do anti-racism work. Like, really be accountable to it and rely upon the communities that they're serving, or work with and engage with the communities that they're serving and the people within the institutions to help them do that. Open a space that is more inclusive, that does provide psychological safety for people, which means you have to have resources and investment and money dedicated to doing this new kind of, this body of work around equity, diversity, inclusion, however you want to frame it, and anti-racism. The resources have to be there. If they're not there, then we're all talking lip service as well. And you can't really fully bring on the expertise that can really create those spaces for safety so that students and residents are able to talk and communicate, provide ideas to reimagine what can happen within their healthcare system that needs to happen. And then I think, again, the institutions need to stand up in solidarity when these attacks happen. And so when they started to happen at the American, for me, I reached out, and the institution supported. They put the resources forward. They listened, and they put the resources forward so that I could have support, so that I could have security detail wherever I go. And that's what I have with me now. And to do like cybersecurity checks, all these things, you have to think about these things ahead of time in the culture that we have in this country, and anticipate that there could be violence perpetrated externally or internally within the institution. So those are some of the things that I think that, immediately that I would say need to be done.
Can I give you a hug?
Sure. I take hugs.
Dr. Phelps.
Dr. Crawford, you're doing great as one of our graduates, and thank you for leading this and all you do and all you're going to do, and just Thank you. Dr. Maybank, thank you. It's a heartening story, and we hopefully we can learn from your feelings and learn from your work at AMA and continue to progress, so thank you. Dr. West, thank you. I will say that when we went to the accrediting bodies of ADEA and came up with some innovative ideas, you were very open and receptive. The site visitors may not have been, but once they left, they were all very excited about a teaching and learning institution having not one, but 2 dental schools. So thank you, and thanks to the folks at ADEA. But let's face it, the education model needs to be revolutionized. It's not so much when the students get in there, because it's the right students getting in there. It's important that we do all the things that we talked about, but it's getting the students into the schools. So when you think about a health professions institution that's starting a medical school or dental school, it's $100 million to $200 million to start one. And when I talk to the presidents, they go, I'm not taking that to my board. So somewhere in the accreditation revolution, we've got to figure out how we can do these things cost effectively so the burden of cost on the students doesn't prevent them from even thinking of going to medical school or dental school or any of the health professions institutions. So we need a revolution in the accreditation and education programs. Things like GPAs and DATs and MCATs, those are built into the system that have been barriers for folks to get into medical schools and dental schools and other schools. And if we don't address those at the accreditation level, the schools really can't change. And so we really need that help. Learning in place is important, especially in today's world with COVID and other things. People want to stay closer to home. They don't necessarily want to go where the dental schools and the medical schools are. They need some other options. Our students come to Arizona for 1 year of medical school, and then they're embedded in community health centers, which once again changes a lot of the students who come to us that aren't from our Pathways program or from our hometown program, but when they go and they do 3 years in a community health center, they're put into an environment that's about love, that's about solving community solutions. So I think that's a very powerful thing for medical school, dental schools, and others to make sure their students are placed in those environments for longer periods of times and not just a 6-week or 8-week rotation. I think when they live there, when they're there for long periods of time, they see things, and Renee can comment to that. And we need to be outcomes-based. Having students come in with a timed program is very, very difficult. Things happen. In our American Indian population, sometimes they need to go back to their home for certain reasons, and even it's not appropriate to ask them why they're leaving, how long they're going to be gone, where they're going, right? That can sometimes have a negative effect on the community and them. So the accrediting bodies, though, and the DOE say, hey, we want to know where these people are every single day and so forth and so on. So we really need the accreditors, and thank you for being here. I wish the other accreditors were here, to realize that it's pre-matriculation that we need to fix. We're fixing, I think, part of that once they matriculate, and then afterwards we're thinking of addressing those issues. But it's really about that pathways that we've got to open up. We've got to revolutionize and change the model of medical and dental education. So, thank you.
Good morning. Excellent discussion, and thank you so much. So my name is Kim Perry. I'm the past 93rd president of the National Dental Association. So Dr. West, I'm very glad that you're here, and Dr. Maybank, we appreciate your comments. Just following up on 2 things. One was the preceptor situation, and I totally understand the dynamics there. You know, we're institutions, we're trying to find locations for our students to be educated, and we know that they need the clinical experience. But is it that the problem is there, and schools need to start looking at how we can reduce these challenges, because we know that students of color don't experience their clinical experiences, and their experiences in school are totally different than their white counterparts. So is the thought that we need to make more meaningful changes so these students who are impacted and be able to take a closer look at this relationship and what that looks like between the school and the preceptor. Does that preceptor need to be a faculty member of the school so they can be held accountable to those standards that our other faculty members are held to? And we do know that it is a challenge. We totally understand that. But there's a small group of students, and particularly students of color, who are experiencing things from faculty members who may not either be aware or choose not to perform the same way as others. And then that leads me to my other comment, and it's that, Dr. West, let me just share that your conference from last last week, it's absolutely amazing. It's just a roar across the country, so we do appreciate that. But the challenge we have is that if you think of it like a barn door with the horses in there, right? The door opened up, horses got out, somebody closed the door, okay? So we educate the faculty members and the teachers who are still, and the students who are still in the barn. What about the horses that got out? What about our colleagues now who are in private practice, who are preceptors now? How do we educate them on these social injustices and things like that, particularly when we have licensure entities who are even refusing to allow states or other entities to bring in continuing education that will address cultural competency. And we're not even asking for this to be required. They're just even suggesting, can you put, because we take continuing education all the time, like CPR, and they won't even allow certain states to bring that type of content onto into that program. So, how is ADIA, how is the American Medical Association helping to handle some of that, because it's multifactorial. You can fix it in your space, but this is multifactorial. Thank you.
Sure. I'll be honest, it is a tough question, but I really think that we have been having conversations with our new ADA Executive Director, Ray Comia, and we have been having conversations that we have never had before, okay? And I think we have some opportunities there to move forward, like this accreditation piece I mentioned. And if we could get backing on many of these things from him, we'll have a foot in the door to make some differences. And that's where I think we start. We have to start at the other professional organizations within dentistry. I know that, for instance, the American Orthodontic Association contacted us and asked us for our information about our D&I team and our what we gave the institutions, et cetera. And they were interested in learning from us. So I think there are some organizations that are trying to do their part, but we can't meet all of them, so I think the ADA is probably our best bet in trying to find those factions in there like Ray who are willing to work with us. We can talk till we're blue in the face sometimes, and things don't change. But if we can get somebody who's a champion for us, who people listen to, then I think that's the way to do it.